Good afternoon, everyone. This is Diane Perez with the Florida Alcohol, Drug, and Abuse Association. I hope you're all doing well. And on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Shame on You, Shame on Me, Shame No More. Practices to decrease stigma and shame in patients with opioid use disorder. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 10 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within that same time frame. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families to help participants track credits earned through attendance. We host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of the registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credit or to access your statement of credit. Do note that the evaluation will close at midnight on Wednesday, May 1st. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are licensed healthcare practitioners, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now I would like to introduce our presenter, Susan Davis Miller. and she is an assistant professor and a clinical pharmacist, obtained her Bachelor's of Science in Sociology from Central Michigan University. She worked in mental health and specialized foster care for several years. She continued to pursue substance abuse education and attained her final degree in pharmacy from Ferris State University. Susan completed a postgraduate year 1 residency program with Missouri Ferris State University and Pfizer, which resulted in a community clinical pharmacy and adjunct faculty position. Susan currently holds a full-time faculty position with Ferris State University College of Pharmacy and a clinical site at Sherri Health Services in Grand Rapids, Michigan. Susan began volunteering with the Grand Rapids Red Project in 2014 and currently serves on their board of directors. She serves on the Kent County Opioid Task Force, Ferris State University Opioid Task Force, the State of Michigan Drug Utilization Review Board, Kent County Pharmacy Association Board, and is the chair of the Michigan Pharmacy Foundation Board of Trustees. She is a co-author of PRONE, Prescription Opioid Overdose and Naloxone Education. And now I'd like to welcome our presenter, Susan. I will turn the presentation over to you.
All right. Can you hear me? If you could put in a question and answer, that would be great. Okay, good. It looks like we're having better connections with our audio now. Thank you for attending this afternoon. My name is Susan DeVries-Miller, and Diane, I appreciate the introduction. Today we're going to spend a couple hours. It sounds like some of you have been busy all day, but you're going to spend a couple hours with me talking about shame on you, shame on me, shame no more, and practices to decrease stigma and shame in patients with opioid use disorder. Please feel free to put comments and questions in the Q&A section. I will try to answer them as much as possible throughout the presentation. However, if I do know that they are going to be answered in the near future, then I will just continue on. This is a new program for me, so I apologize if there's some pauses in between when I'm moving slides. At the completion of this activity, you should be able to define key terms related to opioid use disorder and stigma, describe the relationship between stigma and opioid use disorder and treatment, and identify practices to decrease stigma and shame in patients with opioid use disorder. I would like us to take a couple minutes and to think about stigma. And while we're not in the same room, which is really different for me, I'm used to walking around and interacting with people. If you feel comfortable enough to respond to this, I would like you to, I will not say any names, but I would like you to think about how you have added to stigma as substance use, specifically opioids and medication-assisted treatment. How have you added to stigma? So I'm not talking right now, so that's why it sounds like we've lost volume, but I'm just asking everybody to think for a moment. Some of the comments that are coming in are being judgmental, not being culturally aware, by getting disappointed at failure to succeed, at recovery. These are great ways where we have added to stigma and opioids. So I want you to take another moment to think about how you did not stop stigma. When could you have made a comment to someone to help stop stigma, but you didn't? And again, if you feel comfortable putting something in the chat or the Q&A, that would be great. So we had someone share an old school idea promoted by Alcoholics Anonymous disease concept, or AA disease concept. I can tell you that I remember the first time I had a buprenorphine prescription come in. I was a brand new pharmacist, and it was to be cut into eighths, and I didn't know how to handle that. I don't remember how I did respond, but I do remember instantly thinking, I am not prepared for this. Someone also shared the gender roles using he or she for a transgendered patient. You can continue to put some of those comments in if you feel that something comes to you. I know being on the spot isn't always the easiest, so just let me know if you would like to share in the next few minutes. So this sign comes up on social media quite a bit, and a lot of my friends address it with me. The sign is, why is Narcan free to a dope addict, but my insulin is $750 a month? What does this sign mean to you? Well, to me, I have a lot of concerns about this sign. It indicates one disease is a priority over another. It exemplifies a problem with society today, the lack of caring and compassion about our fellow human beings. There are many memes that imply or state that someone with an addiction is less worthy of receiving life-saving medication, if someone with diabetes is more valuable than someone with an addiction. For me, this is a huge problem. There have been many times when friends and colleagues have challenged me with naloxone for anyone who wants it. There's also times when I've been challenged because people will say, well, if we give them naloxone, people are going to increase their opioid use and they're just going to push the limits. There's a sheriff in Ohio who wants to limit the number of times that his staff will go out to a home for opioid overdoses. My question is, do they limit the number of albuterol treatments? Do we limit the number of insulin? These are directly related to things that we could supposedly control. Why is there one disease different than another, and why is one promoted over another? Well, let's talk about opioids. We could talk about a whole lot of other substances, but since the late 1990s, we have observed a pendulum swing from unlimited opioid pain-relieving medications to our current status. In the 1990s, we had pain as a fifth vital sign. We had pharma companies going out discussing medications to utilize for persons that were in pain. We had accrediting bodies saying that you need to respond to all symptoms of your patients. We had accrediting bodies state, well, if your patients don't like you or if you're not treating their pain, you're going to get lower ratings and you're going to get lower reimbursement. I know in pharmacy school we taught that there was not a limit to opioids, that we didn't realize the fact that we would have opioid overdoses and we would start killing people. So there's a lot of reasons why we need to be talking about opioids. But we also have had a major change because we've had the CDC have recommendations on limiting opioids. I just had a lunch with a public health person today, and they said, but why are you cutting it? I said, The reason that the CDC had those guidelines come out was not for cancer patients, was not for palliative care, and it were guidelines. They were not laws, but we've really taken this to the extreme. You can see here that the trends in the annual opioid prescribing rates by overall and high dosage prescriptions has decreased. Nationally, the rate of opioid prescriptions peaked in the year 2012 and has been decreasing since then. In a new report with data from 2014 to 2017, analysis of patient opioid prescription from National Electronic Health Records vendor found that the percentage of patients prescribed an opioid was higher in rural areas than in urban areas, and there have been significant decreases in opioid prescribing across urban and rural categories after the March 2016 release of the CDC guidelines for prescribing opioids for chronic pain. So we have this major decrease in the prescribing rate per 100 persons. However, you can see here that there's a statistically significant drug overdose death rate. Those in red have increased from 2016 to 2017. I'm in Michigan, dreary, rainy Michigan today, and I'm hoping that Florida is much sunnier. But from Michigan all the way down to Florida, we have had statistically significant drug overdose death rate increases, which is why we have this discussion. You can see from this statistical figure that males and females have had a higher rate of opioid overdose from 1999 to 2017. That is a great question. Why is it going east to get, why is it so easy to get access to this stuff? Well, we are seeing a decrease in the prescriptions, but we're going to talk about some of those trends here in a couple minutes, about the ease of access. We have more people dying from drug overdose than automobile accidents every year. And it's not just males, it's not just females, it is many persons. In this figure, it shows us that from 1999 to the year 2017, we have seen a change in opioid overdose and deaths. We have had a drastic increase from synthetic and from natural and semi-synthetic opioids, from heroin and synthetic opioids other than methadone. We did see an increase in deaths from methadone from 1999 to about 2006, but have stabilized in that area. Going back to that question about why is it so easy to get access to opioids? Well, we've had about 4 waves of the rise in opioid overdose deaths in America. In the 1990s, we had a marked increase in the prescription opioids, which led to an increase in the number of deaths. This arose from many persons being able to get prescription medications. Physicians were encouraged. We did not have limits on the number that could be prescribed. We didn't know all of the dangers of the opioids. Like I said, in pharmacy school, we taught that there was not a limit. It was patient-specific, and we didn't know the correlation between the amount of morphine milliequivalents and the increased risk for opioid overdoses. In 2010, we saw an increase in heroin overdose deaths. This is about the time where we also started realizing that we are having more deaths. We were really trying to figure out this whole pain situation, decrease in those prescriptions. Unfortunately, when persons were not able to get opioids from their prescribers, then they could go to the street and buy, let's say it was Norco. At that time, it could have been Vicodin, it could have been Oxy. They could go to the street and purchase it. Well, that got expensive. Heroin was cheaper than those prescription medications, and so people would start using the heroin. In 2013, we saw an increase in synthetic opioids from the synthetic opioid overdose deaths. And then in May of 2017, we see this 4th wave. A large number of deaths have been related to polysubstance abuse, which includes the mixtures of fentanyl analogs, heroin, prescription opioids, benzodiazepines, cocaine, methamphetamines, and/or amphetamines. And this deadly combination is called gray death. And it's because it's formed into this gray, almost concrete-looking substance that's either injected or inhaled. So we've had those waves, but where are people getting the prescription opioids? This is a study that looked at where people were getting them for the past year of use. You can see that many of the persons who were using it were getting them from a friend or relative for free. And this is divided up in the number of days of past non-medical users. Anybody who used in that past year of the study mainly were getting them for free from a friend or relative, especially those that were using less than 30 days. And the more they used it, the different places they would obtain it from. It could be prescribed by more than one, greater to or equal than one physician. It could have been stolen from a friend or a relative. It could have been purchased from a friend or relative, bought from a drug dealer or other stranger. Most people who abuse prescription opioids get them from free from a friend or relative. However, those that are at highest risk of overdose, and those are the persons that are using prescription opioids non-medically 200 more days a year, and that's on the far right of the diagram, get them in ways that are different from those who use them less frequently. These people are getting opioids. These people get opioids using their own prescriptions about 20% of the time from friends or relatives for free, buying or from friends or relatives, or buying from a drug dealer, which is about 15% of the time. Those at higher risk for overdose are about 4 times more likely than the average user to buy the drugs from a drug dealer or other stranger. We are seeing opioid overdoses on the rise in the United States. There's a 30% increase in emergency department visits for opioid overdoses, and we're seeing great increases in the opioid overdoses for persons 25 and older. In 2017, over 70,000 people died from overdose deaths. Over 15,000 of these were related to heroin, and over 47,000 were total opioid related. On May 3, 2017, Florida declared an emergency, public health emergency related to opioid overdose and deaths. The United States, as designated by our president, declared a public health emergency on October 27, 2017. In 2017, over 30 million people aged 12 and older used an illicit drug in the past 30 days, which corresponds to about 1 in 9 Americans. About 1 in 4 young adults aged 18 to 25 were current illicit drug users. Regardless of the age, the estimates of current illicit drug use for 2017 were driven primarily by marijuana and the misuse of prescription pain relievers. Among these 31 million people aged 12 or older who were current illicit drug users, 26 million were marijuana users, and 3.2 million were current misusers of prescription pain relievers. There are smaller numbers of people who also use cocaine, hallucinogens, methamphetamines, inhalants, or heroin, or current misusers of prescription tranquilizers, stimulants, or sedatives. This breaks down the persons that were using in the past year for opioids. So there were 11.4 million people aged 12 and over in the study that within the past year had opioid misuse. 11.1 million people misused pain relievers. And of them, there was only 10.5 that was solely pain relief misuse. The rest of them used heroin with those pain relievers. There were 886,000 people in the past year that had used heroin, and of them there were 324,000 that used heroin only. So about 562,000 people were using pain relievers and heroin together. This ends up being about 19.7 million people with substance use disorder when we take into consideration all of these medications. Today we're here to focus on opioid use disorder, which has about 2.1 million people diagnosed with opioid use disorder. There are about 1.7 million people with prescription pain reliever and 0.7 million that have heroin use disorder. Now, that doesn't quite add up to the same number, but remember, some of those people may be using both, but are also not considering or reporting all of that. And we'll talk about some of that as we talk about shame and stigma in a few moments. We've talked about the misuse. We've talked about the opportunities. Let's find out about treatment. In 2017, an estimated 20.7 million people aged 12 or older needed substance use treatment. So we have a lot of people who need treatment. This translates to about 1 in 13 people who need it. Among young adults aged 18 to 25, however, about 1 in 7 are in need of treatment. The people that are defined as needing substance use treatment are those that if they've had a substance use disorder in the past year or if they received substance use treatment at a specialty facility in the past year. In 2017, 1.5% of people aged 12 or older, about 4 million, received substance use treatment in the past year, and about 2.5 million received substance use treatment at a specialty facility. About 1 in 8 people aged 12 or older who needed substance use treatment received treatment at a specialty facility in the past year. In 2017, among the estimated 18.2 million people or older who needed treatment but did not receive treatment in that year, about 1 million perceived they had a need for treatment. About 2 in 5 people who perceived a need for treatment but did not receive treatment at a specialty pharmacy were not ready to stop using. But about 1 in 3 reported they had no health care coverage and were not able to afford cost. So the concern is that we have so many people who may need it. We have a few people who receive it, and really very few people are getting it at a treatment facility that focuses on the substance use that they have. And we have a lot of people who are not able to afford treatment. All right, that's the boring background stuff that we have to get through. Let's talk about definitions and impact of shame and stigma in opioid use disorder. How many of us have made assumptions about the behaviors of our patients? I have quite a few pictures that I usually do a quiz with people when I'm live, and I will say, what does this represent to you? What instantly comes to your head when you think of these pictures? We all know about the public health crisis. We all know people who use opioids. We know about the public health crisis and that we shouldn't be using them and the reasons not to be using opioids. And we have concerns. But when you have a patient who may look like this, do you think about helping them? Do you think about the treatments that they're receiving? Or is there judgmental statements that go along with it? I can tell you that in the areas that I work with, there are a lot of people who make judgment based upon the patient coming in, whether or not they've worked an overnight shift or they've had a history with the staff of using the medications inappropriately. And so we have to take into consideration when people come to us, we should not be judging. We can take into consideration to get the whole picture of a patient, but we should not be judging them by what we see. Which leads us into knowing the differences between tolerance, dependence, and addiction. I believe most of you are in treatment facility centers or work with medication-assisted treatment, so you understand the differences between tolerance, dependence, and addiction. But I want to review it because I want us to really think about this. Even though I present this quite a bit, sometimes I just take a step back and say, yeah, that's right. I just needed that reassurance that this was what we were doing. So let's talk about the mesolimbic pathway. The pathway consists of the VTA and the nucleus accumbens and is responsible for learning and controlling desirable behaviors of an individual. The neurotransmitter responsible for the pleasure effect is dopamine, and is generally found in areas of the brain that coordinate a person's movement, emotion, and perception of satisfaction and pleasure. During homeostatic conditions, dopamine fuels the brain's reward system. This activation of this pathway is significant, and it promotes learning and committing actions to memory, which encourages an individual to repeat that specific desirable behavior to achieve that said pleasurable effect. But most drugs of abuse, including opioids, target the mesolimbic reward pathways and increase dopamine neurotransmission within specific areas of the brain. Activation of the kappa opioid receptor within the nucleus accumbens region increases the release of dopamine. Stimulation of the mu opioid receptors inhibits the release of GABA within the VTA, which normally inhibits dopamine release, leading to drug abuse and addiction. In cases of chronic use, the body can become desensitized to the opioid, causing a decrease in pharmacological response to the drug and the body's dopamine release. This leads the user to increase the dose in order to achieve similar effects, a phenomenon known as tolerance. Depending on the period, the extent, dosage, frequency, and pharmacokinetic factors, tolerance can reach toxic levels, which can lead to irreversible damage of organs, overdose, and even death. And then once a person has developed tolerance, and quite honestly, it doesn't take long to develop tolerance, but once somebody were to have that high dose or chronic doses abruptly discontinued, we would see withdrawal symptoms because they're dependent upon that medication. When we have the changes in behavior, despite the potential side effects and harm, which I'm going to go through the opioid use disorder diagnosis, we would see that as addiction. I'm going to take a little drink of water here because I'm talking so much. So, shame. We have all felt shame before. When we've had a failure at work, at home, with friends, in public. Sometimes it's very small, and it doesn't last long. That's called acute shame. And it's a painful feeling of humiliation or distress caused by the consciousness of wrong or foolish behavior. It might be a loss of respect or esteem. People would say it's dishonor. It is a regrettable or unfortunate situation or action. If it is recurring or persistent, it can have a negative impact on health, and that is called chronic shame. According to the Compass of Shame by Donald Nathanson, there are 4 roles of shame, or 4 responses to shame. So there's actually a compass. I don't have it on the slide. I apologize, but I can share that information as well. But the 4 poles of this compass are withdrawal. So a patient or a person who experiences shame may withdraw. They will isolate, they may run, they may hide. Another way that they might respond is attacking their self. They may attack themselves physically or mentally. They might put themselves down or even harm their bodies. We may see that as cutting or self-harm in other ways. Another pole of the compass is avoidance. We might deny the feelings of shame altogether. Some might abuse drugs or distract themselves through thrill-seeking in order to avoid those feelings of shame. And another way that someone may respond is attacking others. They lash out at others or at property. They might turn the tables verbally or physically and assault others. They may blame others for their feelings of shame. So we see a lot of persons becoming uncomfortable when they feel shame, which leads to avoiding, ignoring, or attacking. And this is different from stigma. Stigma, according to Oxford Dictionary, is a mark of disgrace associated with a particular circumstance, quality, or person. In medicine, it's called stigmata. a visible sign or characteristic of a disease. A self-conscious emotion informs one of the internal state of inadequacy, unworthiness, dishonor, regret, or disconnection. The process of stigmatization labels the differences and assigns which attribute or which group or the stereotype is negative. There is a purpose, unfortunately, to shame and stigma. I knew I was going to mess those up, sorry, shame and stigma, but it's not positive. The purpose is fourfold. It regulates, isolates, relegates, and discriminates. It regulates which attributes are mainstream. It controls and forces behaviors that are marginalized. Isolates those who are stigmatized. It relegates means that it distinguishes those who should be stigmatized, and it discriminates against persons with those label differences. And we can see this in many ways. Like I said, there have been times when each of us may have been shamed, and it might have been if you were dressed differently than someone else, or said something that did not quite fit in with the rest of the people that were present. There are rules, sometimes unsaid, sometimes said. We can see this everywhere we are through media. There are commercials. One that instantly came to my mind was the commercial with the shirt. The guy's on a first date and it's wrinkled. And it's really interesting because nobody wants somebody with a wrinkled shirt. Like, that changes who they are as a person. Maybe that's not important to them. Pretty benign, but unfortunately, media has stigmatized that. We've also, unfortunately, in our society, stigmatized those with mental health, substance use, and medical conditions. I'm going to give you some personal information about my life. My husband, many years ago, was in the military and had some disabilities upon discharge. And he's had multiple surgeries to fix the things that happened from his military career. And when he had one of his reconstructive surgeries, I was a social worker. I'm such a rule follower. I was giving him all his prescriptions exactly how we were told, and there was pain medicine. There was some medicines for his muscles, which I know are like a Flexeril or just to relax, it's a muscle relaxant. He was on an antidepressant because of the injuries had caused a lot of pain and depression, and then he was also on an anti-anxiety med at that time. I was giving him the medications around the clock as I was supposed to. Thankfully, he wasn't able to wake up fully and would not take the medication. Unfortunately, he was having medication-drug interactions, and it was leading to an opioid overdose. Had I continued to give him those medications, he may not be with me today. But I didn't know. No one talked about it. And I didn't talk about this for a long time because it's pretty shameful that I possibly helped with this situation with my husband. But I was at an opioid task force about 2 or 3 years ago, and I shared this story. And one of my colleagues, who is a social worker professor, came up to me afterwards, put his hand on my shoulder, and said, "How long has your husband been in recovery?" I was shocked because not once did I say that my husband had an addiction, that he misused the medication, that we went through treatment. But it was instantly assumed that my husband had an addiction because of this potential overdose. So there's a perception of moral failing in shame and stigma. And then there's judgment. And then people label. And it's a stereotype, which that solidifies the stigma. And then the response by the person who is being stigmatized or feels shame is withdrawal because they are unworthy and they may go into isolation. There may be punishment, there may be separation, and definitely criminalization as a result of these stigmas. There can be collateral consequences. We can see people going to prison. We can see people avoiding others, not seeking treatment. And there are status changes. and all of this leads to discrimination. Today, when I was talking with my colleague about my presentation, she was talking about how her mother went in for surgery a few weeks ago, and they said, well, this is the prescription that you'll have after your surgery. And she said, I'm not going to be part of the crisis. And they said, I'm sorry? And she said, I don't want an opioid. And they said, you're going to need an opioid. This is a major surgery. And she said, I'm not going to be a part of the crisis. I'm scared of that. So we have a lot of fear-mongering. Many decades ago, 70s and 80s, we women and children were told that you should be afraid of black drug users. Black men were drug users. There was a political agenda. There was stereotyping, and there was criminalization. Now we have the opioid public health crisis, and many people have said to me, well, it's only because Caucasians are impacted. It's pretty frustrating that we have the shame and stigma that's added on to a person's race, on their identity, as well as on top of any misuse or use of medication. And quite honestly, with shame and stigma, there's also that fear of arrest. It is illegal to have drug paraphernalia in the state of Michigan. If you have needles without a prescription, you can be arrested in certain areas. So what is the impact of shame and stigma? Well, I'm going to stop and look at some of these comments. It's natural to fight back when you're attacked through stigma, absolutely. People stigmatize others and makes them feel important, which is really sad that that's how people feel, but we have such an impact. I'm going to talk about how we can make a difference with that in the second half of the talk today. The impact is on health, because there is a fear of arrest with the drug paraphernalia that I just spoke about. We have poor health outcomes. There are people who do not seek treatment because of the judgment and the stigma and the shame that goes along with it. If you saw what a needle looks like after it's been used 1 or 2 times, I shudder at the thought of somebody not having clean needles if they are using because of the pain that it could cause them. Look at Scott County, Indiana, where in a very short amount of time, there was about 140 people due to unsafe practices. They did not have harm reduction services available to them, and they were sharing needles. They contracted hepatitis C and HIV. When we have the impact of shame and stigma is it limits access to care or services. People do not ask for harm reduction when they're being judged. There's internalization of the shame and stigma. A person feels less worthy, therefore it's harder for them to change because they've created an identity. They are that person. There are places that they go to where they're labeled or stigmatized as that person. There's discrimination. Maybe their primary care doctor or their dentist, or if they go see an eye doctor, maybe they have made comments in the lobby. They have been discriminatory. And then the word gets out. Oh, people who misuse or use or have an addiction are not welcome here. And then people don't want to return. Or people are afraid of having that population visit their clinics. There are threats of shame. It could be from the provider, the staff. It could be from other persons at the clinic. It could be a failure to seek treatment because of this threat of shame. A lot of people will conceal or fail to disclose what's really happening in their world if they are not treated with respect. And even if they are given a referral for any types of treatment, any type of treatment at a provider's office, they may not follow through if they have any hesitancy due to shame or stigma. But wouldn't it be great if we didn't have shame and stigma? But we do, and there is a large impact. With the history of drug use in the United States, which has varied from overuse of prescription to illicit, drug use in the 70s, 80s, and 90s were stereotyped to mainly low socioeconomic status, minorities, and in urban areas, even though we know this is not true. I've heard from many people in town halls that the reason the opioid public health crisis is so visible is because it is not impacting this group of people at this time. It's impacting all persons, as we saw from the beginning. Let's talk a little bit more about shame and stigma with all of the things that are happening in a person's world. So there's shame and stigma related prior to even using any opioids. So if somebody is on a prescription medication, it might be okay, or people don't want to be part of the crisis, as I heard earlier today. And it also depends, like, oh, were you getting high with your friends? Were you using with your friends? It's part of the words that people use is to the reasons whether or not it's shame or stigmatized. If you have persons that are in treatment, it may be perceived differently as to why they used and what was happening prior to use. And persons that use and misuse do perceive things to be different. If you are using prescription medications, maybe it's a little bit okay, unless it gets out of control. But if it's illicit, there's also sometimes where it might be okay. Well, maybe you just smoke marijuana, but if you are an opioid user and you've misused it and now you're at heroin, maybe it's different. Or sometimes there are people who prefer or are more accepting if it started with a prescription and then it went to another form, whether somebody was snorting or inhaling it or smoking or intravenously. And it also depends on the person that you're speaking to, what their drug history is. And then maybe it's okay or not okay in certain situations. So let's say you're a person who has been using heroin and you're injecting it, but you've always purchased it and you've never traded for sex. But the people who trade for sex are bad because there's more stigma with that. So really, there's a ton of different ways that we can shame and stigmatize people based upon all these different ways that people use it, when they use it, how they started it, and how they're getting it. And even with treatment, it's pretty interesting to me that we're going to talk about this a little bit later, is in the persons that are in Narcotics Anonymous, how they feel about treatment. Abstinence is what has been traditionally accepted. But do we accept it as medication-assisted treatment? Is it only short-term, or is it lifetime? These are all reasons that people shame and stigmatize each other. There are providers, and there are peers, and there are community members who may have different perceptions based upon each one of these situations. And it even changes with persons and relationships. Relationships have an impact on the shame that one feels. Parents and family members feel the shame and stigma, but they perceive it differently. A family versus a coworker who doesn't show up to work or is late, people may perceive that differently. In a study by Kennedy, Hendricks, and colleagues, they found 78% of the respondents felt that individuals were responsible for their own prescription opioid use disorder. 72% indicated that some lack of self-discipline to use prescription opioids without becoming addicted. So they felt that there was a lack of self-discipline for persons who became addicted. Other findings were that employers should be allowed to deny employment to those with prescription opioid use dependence or disorder. And 68% of people said they would not want or willing to have someone marry into their family who had prescription opioid use disorder. Another study in 2013 said 90% were unwilling for someone with SUD to marry into a family. So it really depends upon if it's your family member, if they're marrying in some of the behaviors, and also if there could be more stigma with a coworker or less acceptance because of the impact it has on people. We have defined shame and stigma, and now let's talk about opioids a little bit more. The good and the bad. I'm not certain that these are all good or all bad, so you can determine which are good and bad for you. There could be pain relief. There could be positive reinforcement. There could be emotional distress relief. sedation, and a hug. I've heard people define the opioid response is the hug that they have not felt before. And then some of the side effects that go along with it is constipation, sedation, confusion, QTC prolongation, pruritus, hyperalgesia, respiratory depression, decreased testosterone, and opioid use disorder, which is what we are talking about today. And I just want to remind us about the definition of opioid use disorder per the DSM-5, that you have to have 2 within the previous, or in the, that occurring in the 12-month period. So taking larger amounts. We talked about tolerance. A persistent desire, unsuccessful efforts to cut down or control opioid use. Spending a great deal of time obtaining or using. Cravings or strong desire. Problems fulfilling obligations at work, school, or home. Continued opioid use despite having recurring social or interpersonal problems. Giving up or reducing activities because of opioid use. Using opioids in physically hazardous situations. Continued opioid use despite ongoing physical or psychological problems likely to have been caused or worsened by opioids. And then tolerance. And experiencing withdrawal or taking opioids or closely related substance to relieve or avoid withdrawal symptoms. And so we have persons that are non-medical, non-understanding persons who could take these signs and symptoms and really stigmatize people. I want to, before I go, I'm going to lead into break here in a moment, but I want to answer some of the questions. So a comment is a drug. The issue is drug misuse. Yes. What is QTC prolongation? It is a heart arrhythmia that can happen for persons who are using opioids. When we have persons, we see it a lot, not a lot, it's actually extremely rare. It's called torsades, and persons can have an arrhythmia and it can cause death. But persons that are on medication-assisted treatment with methadone, we typically do a background to make sure that no one has that when we're getting to higher doses or has a family history of it. And even when we're putting somebody on an opioid, we do ask those questions. Sometimes we do an EKG for patients if we know there's a family history. And there are certain people who are at higher risk. So older women are at higher risk for QTC prolongation. It just really depends upon the situation. But it's something that health care providers should be looking at, especially when we're looking at high doses of methadone. All right. So after break, we're going to talk about stigma with OUD. I was told that we have about a 5-minute break. Diane? Okay. Shall we go to that now?
That would be great. Let's go ahead and take a 5-minute break. We'll come back at 2:58, and we'll see you in about 5 minutes. Welcome back to today's webinar. Susan, if you're ready, I'll turn the presentation back over to you.
All right. So why is there stigma with opioid use disorder? All right. We have a few reasons that we're going to go through. The misconception of weakness or choice, separation of healthcare and opioid use disorder, language, our criminal justice system, outcomes, and we're also going to talk about some models. For the misconception of weakness or choice, people believe that it's a willful choice of the person. There is stigma with opioid use disorder, and we condemn the person. With prescription opioid use disorder, there's less of a stigma. And like we talked about a few minutes ago, that degree of relationship, whether you're the parents or the colleagues. And recovery depends upon willpower. It doesn't allow for medication-assisted treatment or only allows for tapering off medication-assisted treatment. Some people even believe that medication-assisted treatment is a weaker strategy rather than the treatment. I work mainly with patients with chronic disease such as asthma, COPD, diabetes, depression, and pain. And with all of these, I work with mental health and persons that have addiction. And there are issues and concerns with each of the medical diseases, if we want to call it medical diseases. I speak or discuss with my patients about the patho of the disease, the lifestyles, the impact, basically the whole person. When speaking with my patients with COPD, we discuss smoking exposure. I ask what exposure they have to smoke, and we talk about its impact. If someone wants to remove the exposure, then we discuss the steps to this. This is similar when I'm working with patients with opioid use, without judgment and without negativity. But that's not always what happens. As I was speaking earlier, we talked about Narcotics Anonymous. The foundation principle is complete abstinence. There are some different viewpoints in that, but the misconception of the weakness or choice, and that allowing persons to have some choices in their treatment is not always accepted. Or medication-assisted treatment might be accepted for a short duration. It's interesting because with my patients with diabetes, insulin is for a lifetime. With asthma, they may need a controller for their entire life. Allergies, they probably need treatment, especially if you're in Michigan and we go through several seasonal changes. But what if we said you could only have those medications for a short amount of time? Just as we do with opioid use disorder. So we have to be cautious in our misconceptions. In the separation of healthcare and opioid use disorders, providers treat their diseases. Primary care may not treat opioid use disorder, and if they do, they may not feel confident enough to fully treat it or understand or appreciate the impact it has on the whole person. And then if their primary care provider isn't treating their opioid use disorder and doesn't understand it, they may have some stigma towards opioid use disorder and the symptoms, or their staff. And there are the concerns about medications treat one disease state. We have buprenorphine, methadone, which are treatments for opioid use disorder, but they're not necessarily used for substance use disorder or for polysubstance use. And you may have to go to different providers to get medications for different situations. So if you do have diabetes and you're on medication-assisted treatment, you have to go to 2 different places to get the prescriptions for those medications and have different appointments for those. We are seeing more persons in the state of Michigan get their XDA and increase the number of persons who are in buprenorphine, but with all the regulations and policies, the primary care provider is not always comfortable with prescribing methadone, and quite honestly, in the state of Michigan and in most places, you have to have a special facility for that. The policies, if the primary care provider is comfortable with treating opioid use disorder, they do not always know how to prescribe and monitor or counsel or provide resources. If their staff is trained to provide appropriate care, it could be meaningful to make sure that everybody understands opioid use disorder, because we can have shame and stigma in our staff even if our providers are not portraying that. So we need to make sure that there is a safe and supportive environment if we're going to have the togetherness. And regulations for medication-assisted treatment. Right now, there is a lot of paperwork that has to be done for primary care providers to prescribe their buprenorphine or methadone and follow up and making sure that they're doing everything that's appropriate and necessary for a person. But then, even if they do have all of that in place, the reimbursement may be limiting. Patients with opioid use disorder may require additional services. And if there is one payment per patient, they may not feel that they want to have those services in their clinics. So additional services may require part of the process having urine drug screens. Counseling is very important to make sure it's part of that. And then if there's any pharmacological treatment. Another reason for this is the language that is used. Do not talk about it. If you are a person that has opioid use, you should not talk about it, or opioid misuse or opioid use disorder, you don't talk about it. Another thing that we have to be cautious of is that terminology, even when we are using it. I've caught myself at least 2 times on this presentation using terms that I've tried really hard to not use. And so that terminology can be stigmatizing. When we talk about detoxification, that might be decreasing the doses of the medication, or we send patients to detox, but that means that there are toxins and that the person is poisonous. Nobody wants to be called poisonous. We don't want to be called dirty. But if we call them clean now, that means they were once dirty. So even the words that we use, or they're drug seeking, instead of stating the patient is called early 2 times each in the past 2 months for early refills, we can state facts. We don't have to say they're drug seeking. Stating facts takes away that stigmatization. Making a supportive environment is not solely the responsibility of providers, is for all staff. From security, making sure that somebody's going in to use the bathroom, security isn't following them or stigmatizing or shaming people. Administrative personnel, making sure that they have appropriate trainings for all people that are employed. For our medical assistants, to our nurses, to our technicians, to our pharmacists, to our healthcare providers, our social workers, everyone needs to make sure that we are not using inappropriate language. Or even using the words drug-free treatment. You must be sober. And if you could see me, my face is pretty sarcastic right now. Because what does this mean to have a drug-free treatment or to be sober? Does this mean that people who are in medication-assisted treatment are not in treatment? Medication-assisted treatment is life-saving as much as insulin is for a person with diabetes. It's not a recovery, it's a treatment. We have to make sure that we're understanding that we should not be judgmental in our language and that we're stigmatizing persons with opioid use disorder. We want to make sure we are not facilitating a negative environment. And yet another way is with the criminal justice system. Some judges have refused, even prohibited, to allow persons with opioid use disorder to utilize medication-assisted treatment while incarcerated. In Michigan, we do have programs that are allowing for persons to continue utilizing medication-assisted treatment if they've already been started on it. But the problem is that that's a great time to work with somebody when they're incarcerated, because we are seeing high incidence of overdoses after being released from prison and jail. But if we could start medication-assisted treatment when somebody's incarcerated or while they're on probation, then we would have more opportunities to help people get into treatment. While persons are in the criminal justice system, they go through a withdrawal. Some think this is a good idea, but how ethical is it for someone to go through all of the withdrawal symptoms? We don't allow this with other diseases. We don't allow people to go without inhalers. We don't allow people to go without insulin and things of that nature. But we allow those to go through withdrawal without treatment. And this decreases their tolerance, but it does not decrease their cravings. When released from their criminal justice system, they return to using at the same doses and can be at a higher risk for a fatal overdose. So that the criminal justice system is really a system of punishing people. And some of the outcomes that are occurring with the stigma with opioid use disorder and the stigma is the impact of stigmatization has proven itself deadly in the United States. It limits willingness to access care and services and leads to discrimination and internalization. It also can lead to overdose. We see the higher rates of opioid overdose while prescription counts are decreasing. We are also seeing that we have a lot of relapse and recovery, but we're not really looking at it as a positive. In a study of Stumbo and colleagues, patients reported treatment barriers included fear of uncontrolled pain may inhibit efforts to reduce pain or seek treatment for opioid use disorder. I have some quotes here from people who have said this actual statement about their fear with the treatment barriers. I just never got off the painkillers. The pain is excruciating without anything. The solution is staying on the medication. I've talked to my doctor about just putting me on a weekly program to where I can only fill it once a week, and that way I don't overtake it. This is regarding methadone. Like if I do overdo it 1 week, at least I'm only out a day or so. But if I have a whole month, then I have to go a few days without anything, and the pain that I deal with, it's impossible. And so people have that fear of uncontrolled pain. I had a patient that I was doing an opioid taper off methadone, and it wasn't because of opioid use disorder, but we were decreasing it, and his fear of not decreasing the methadone was this pain. And he was on extremely high doses of opioids, and through the process, we realized that there was opioid use disorder, but it was really that fear of pain that was his reason for not wanting to get to a more manageable medication level. And then in the same study, and these are all persons that had insurance coverage. Earlier we talked about many people don't have insurance coverage, and for people that do have insurance coverage, there's still that stigma of addiction. And it varies with those who started with prescription versus illicit, even those that have the diagnosis of opioid use disorder. And an outpatient methadone program was probably one of the most demoralizing things I've ever had to go through, one participant said. I'm a soccer mom, and I also have major serious addiction issues. But at the clinic, I've never felt more like a drug addict in my life. So those words, drug addict. I didn't have a lot in common with the majority of the clientele there. My lifestyle, my life circumstances were different. If I had been there 10 years earlier, it would have destroyed me. I have a little more strength, and I'm a little more mature, so I was able to hold onto my own identity while I was there. I would leave there feeling like a junkie. People offered me drugs there. They knew I was in pain. That's how I ended up there. They would offer me their drugs. They're not even trying to get clean. It was horrible. So even the words that were used by these people that were in the study were of stigmatizing and shamefulness. And in treatment, providers cannot even agree on the best treatment that's out there. And so how are persons supposed to respond to that? In the 90s, we said opioids for everybody, and then we said no opioids. People, are like, oh, what are we supposed to be on which side of the pendulum? Oh, there's a crisis. I want no opioids. So even the stigma that goes along with opioids or opioid use disorder, people just can't agree. So it's all a stigma. And there are a few models of thought that also are part of the stigma in opioid use disorder. So if these are framings or models for substance use disorder, and it's really interesting how people think that they should be categorized. So the models of thought can be criminal, moral, disease, and public health, and these are just four of the major ones. It's a criminal diagnosis. Opioid use disorder, people who misuse or abuse opioids, it's a crime. It's illegal behavior. They should be incarcerated. They should be put away. They are just bad. And then there's the moral thought that drug use is wrong. Drug users need to stop. Goes back to that willing and willfulness. It's that misconception. It's interesting because if we look at the disease model, it's addiction is a disease, and we treat it medically. And this is really where we should be at, making sure that we are treating this as a disease. And then there's the public health model. Drug use can result in negative health outcomes, and the impacts need to be decreased. So it's looking at the general population. So disease model should be predominant, but unfortunately, the criminal model is predominant. The public health model is an alternative for us to look at, so there's no judgment, that we can have positive negative behaviors, but that we want to decrease negative behaviors and increase positive behaviors. So what is the impact of stigma in opioid use disorder? We've basically talked about these, that it is discriminating. We find people are discriminated based upon their opioid use disorder, and even persons that have opioid use disorder discriminate against other persons that have opioid use disorder based upon their patterns. It's disempowering. People become what they're labeled. And they isolate, they respond, they isolate, or they attack, and we reviewed that earlier. They're marginalized. People are marginalized based upon the stigma of opioid use disorder. They're not always fought for, they're not always advocated, and they are excluded. And at times, people can be unwilling to seek help, and there's a lot of shame that goes with those stigmas. Like we said, we withdraw, and there's self-harm, and there's blame, and all of this just exacerbates the previous one, because if you are withdrawing, you're now marginalized. People continue to discriminate, you withdraw some more. So the impact can be cyclic. But we can have an impact on this. We can shame no more. So how do we as providers, as healthcare team members, impact stigma and shame? We are involved in preventing, diagnosing, and treating our patients. We also have a voice. We can make a large impact. And I know that providers can make a large impact because early in my pharmacy career, there was a change in the rules. The public health code said there had to be a certain diagnosis on all stimulants for persons under the age of 18. So the day that that took effect, we were no longer able to dispense medications. So we'd tell the patients, I'm sorry, we can't give you this medication today. You have to go back to your doctor and get a new prescription. Within 24 hours, that rule had been overturned. If we can overturn a rule in 24 hours, we can make change altogether and quickly. All right, each time we interact with our patients, we can ask about where patients are in a very non-judgmental fashion about their stage of change. Asking a patient to tell us where they're at and not shaming them. Making sure our patients understand that each step is part of the process, that we need to know where they are in their opioid use disorder, if they are in pre-contemplation, contemplation, preparation, action, or maintenance, and also relapse and recovery. Having these conversations every time we see them, making it as easy as to say, What are your sugar levels? When was the last time you had to use your rescue inhaler? How is your weight when we're talking about obesity and different things? Making it easy part of our conversations. And we need to make sure that our patients understand recovery and relapse is going to possibly occur, and that we want them to talk with us about it because this is a chronic disease state. Often, opioid use disorder persons resist treatment, but treatment options should be continuously encouraged. Relapse is also common and indicates that one or more different treatments are necessary. Let's go through each of these pretty quickly. Pre-contemplation, our patient is, I don't have a problem. I could stop if I wanted to. I just don't want to. Contemplation, maybe I do have a problem. Maybe, my relationships are ending because I am using, or I'm not participating in that relationship. Or, the last time I was incarcerated, or I went to the hospital and it really scared me. But in the preparation phase, we can start to make a plan. And it's working with the patient. It's not having a one-size-fits-all. We definitely need to have treatment plans that are individualized. So working together with our patients with opioid use disorder. And then we have the action phase. Let's do this plan. What are you going to do? And then we're going to also include in there the maintenance, like the monitoring part of that as well. Because we have the potential to grow, change, and develop over time. It is all going to be gradual and yet constant, and helping patients realize when you relapse, which may be part of your recovery, then we need to say what didn't work for you. And we're going to come up with some newer, different ideas. We need things to be better if it's not working. We need to meet people where they are at in each part of these stages of change. So really having open conversations with patients, making sure that they understand that wherever they are in that change or in their change stages, that we are right there with them. But we can also prevent opioid use disorder. We can have open conversations prior to prescribing, or if we have a patient that has a family history of opioid use disorder, having those conversations before there's even a prescription, at each of the refills, having a conversation about this, having a plan as to when medications are going to be discontinued. If you have a patient who is taking prescription opioids, you don't want to stop it cold turkey for multiple reasons that we've talked about today. So how do we work on this plan to discontinue this medication? Do we do medication-assisted treatment with this? And another thing that we can do is pharmacogenomics. We can really make sure that we understand that there's pharmacogenomics that show us that there's increased risk for relapse and that there's increased risk for having a family history of opioid use disorder. These are some of the things that we just talked about, that personal history or family history. If you have a patient that has opioid use disorder and they're going to have a surgery, having a conversation with that person about how do we do this? If it's a minor surgery, are you willing to bear through this? Or is it a major surgery and we need a plan? Is that you have a family history that when you have 3 members in the family had dental procedures and remained on those opioids for a very long time, which led to opioid use disorder? Is it that? So having those conversations about all of these things, and then realizing that adverse childhood experiences can impact the reason for misuse. The CDC had a study with Kaiser on adverse childhood experiences, and this is just a very general representation that shows us that when we have adverse childhood experiences, it can impact our neurodevelopment, our social-emotional cognitive impairment, and that there's an adoption of some risky behaviors at times. It can lead to early death. It can have a lot of impact on it. And so knowing these adverse childhood experiences that our patient has can be very helpful, because the more that a person has, the higher the risk of becoming an intravenous drug user. A score greater than 6 indicates a higher risk. And so if somebody has any of these, alcoholism or alcohol abuse in their family, COPD, depression, fetal death, health-related quality of life, illicit drug use, ischemic heart disease, liver disease, poor health performance, financial stress, risk for intimate partner violence, multiple sex partners, sexually transmitted diseases, smoking, suicide attempts, unintended pregnancies, early initiation of smoking, early initiation of sexual activity, adolescent pregnancy, risk for sexual violence, and poor academic achievement. Knowing some of those factors impact whether or not we have higher risks for using drugs or having opioid overdose is really helpful. So addressing that with our patients. And then in all of our treatment, we need to make sure that we are patient-focused. Is the patient involved in the treatment plan? Is it focused on their needs? And looking at it as chronic disease management. We're going to talk about this every time. But also, we're not going to focus on it and demoralize someone or stigmatize. Making sure that a patient has access to all the treatments that are out there. Is naltrexone, buprenorphine, or methadone the best one for your patients? We also want to make sure it's coordinated and we have behavioral interventions. We want to make sure that everybody has the support services that they need, whether it is coordinating to make sure it's in the same location or that it's by trained professionals. Are there mutual aid groups? Are there peer support specialists and community services, making sure that all of their treatment needs are being met? Especially when it comes to medication-assisted treatment. Do we have the knowledge, and does the patient have the knowledge on all of these? Do we have the opportunity for methadone if that is what the patient wants? And do they know what methadone is? Do we understand buprenorphine? Do we have opportunity for naltrexone? Are we having that open communication, all the patient-centeredness? Are we focused on non-stigmatizing and non-shaming words? Does someone realize that medication-assisted treatment could last a long time? In one day, I was seeing 2 different persons, and I was meeting with the provider right beforehand, and the provider said, I want you to get this person to stop smoking. I said, well, okay. So I go in, and the patient says to me, you know what, I am on methadone, and I want to quit smoking. But I also really like to start weaning myself off from the methadone. And I said, let me ask you a couple questions, please. And I said, okay. I said, well, how long were you using opioids before you were on methadone? And they told me their time frame. I said, okay. I said, and how long have you been on methadone? And they told me the few months that they had been on it. I said, and now you're telling me you want to stop this as well as quit smoking. I said, I will not help you with that. What I will help you with is understanding that the duration that we should be on methadone is not just a few months. You are feeling great right now, and I appreciate that, and I support that, but I want to continue to support you through a lot longer because it's not going to be a quick treatment plan. The patients did not, and this was a very similar conversation with the next gentleman too. And so I go back and I tell the provider, I said, I do not support smoking cessation with these patients. We have them, they're opioid use disorder patients, or patients with opioid use disorder, and they're doing great. Why would we want to give them a tailspin or potential tailspin? Let's support them, and if they want to continue to cut back slowly on smoking, that's exactly what I did. But I'm not going to have them take off the smoking as well as taper off the methadone. In fact, I said, we're slowly going to encourage them to do smoking cessation. So even the conversations that we have it has to be focused about the duration and the concern of relapse and the long-term treatment plan that we can have. We need patients to understand that medication-assisted treatment is not always short-term. We need to improve access to treatment. We talked earlier about how many people needed it, how many people actually received it, and only 2.5 million people receive it at a specialty facility. That means that 4 million people may not have had the services that were specialized for their drug of choice, or if it was opioid use disorder, or getting the knowledge and the support that they needed. And we have a lot of people who cannot afford the cost of it. I know people who spent $25,000 for 1 month of treatment. They had the resources. I know people who spent it 3 or 4 times. It was specialty treatment, and it didn't work. But if you don't have insurance, you don't even get the opportunity to go into treatment. And this is a big one because a lot of the things that I've even said today are hard to do, and I work on this a lot, but modifying our language needs to be a priority. When I'm saying medication-assisted treatment, that can even have a negative connotation. There's a study out there, and I don't know if I'm going to go through that. I'll talk about that in a couple minutes, but opioid agonist treatment may be even better accepted by people than medication-assisted treatment. It is all in the words, all in the shame and stigma that our society has been utilizing. So some of those negative words are dirty, clean, because if you're saying clean, it might sound like a positive word, but it represents that at one point they weren't clean. Using an addict or junkie, and we heard somebody with opioid use disorder in a study that called themselves an addict and a junkie. And if you go to Narcotics Anonymous website, they use the word addict. And they use a lot of these negative words, but it may be more accepted if you are living with opioid use disorder or a person who has opioid use disorder versus somebody who is a treatment provider. Another one is your habit. What's your habit? Again, clean can just be a word that we really need to make sure we're not using, or dirty drop, or abuse, or overdose. The positive terms are present or not present, substance-free, person with opioid use disorder, or conditioned, recovery. It's detectable. There's misuse or use. And for overdose, some of the words that are being recommended are poisoning or unintentional overdose. Some other wording that I wanted to share with you, I do a lot with harm reduction. I'm very involved in the Red Project here in Grand Rapids, and it's a harm reduction agency. And we don't do supervised injections, but I know there's a lot of talk around the United States of do we do them, do we not do them? Seattle right now is approved to do them, but nobody is really stepping up to do a safe injection site. But it's interesting because the wording of safe injection site or supervised injection site versus an opioid prevention site. In a study by Berry in 2018, 45% of respondents supported legalizing overdose prevention sites compared with 29% supporting safe consumption sites. This is a statistically significant 16 percentage point difference. It's interesting because there is the whole wording of supervised injection facility or safe consumption site. It talks about that illegal behavior, invokes a moralistic interpretation. The wording focuses on the stigmatized action, whereas the wording of overdose prevention site focuses on the public health, and that's where we go back to that model or framing in the public health and safety purposes of the site. It shifts away from the perception of individualized cause and concerns. It emphasizes the notion that prevention of deaths are occurring. So it's a public health model shift. It shifts away from the emphasis, and it really shifts away from that safe injection and that criminal stigmatized behavior. So one of the things that we want to make sure that we're doing is not describing people by their diagnosis or their drug use. We want to make sure that we remember that people are complex and have many identities. I am Susan, and I have a husband who almost died of an opioid overdose. I am a mom. I have prediabetes. I have this. I have that. There are many things about me, but not one of them identifies who I am. Therefore, I am not pre-diabetic. That is not who I am. I am Susan. I am a person. We do not use morally loaded descriptions. We avoid language to describe the negative states. The person had a urine drug screen today, and this was present. We could say, oh, they had a dirty drop, but that's really negative. We need to value the person. We need to remember that language can bridge or it can marginalize. We need to recognize people are making the choices that they feel that they have with the tools and resources that they currently have. So we need to make sure that we are also giving them with more tools, giving them the tools. And then we also need to focus on changing policies. Healthcare coverage for opioid use disorder, for medication treatment, or opioid agonist treatment. We need to make sure that somebody has availability of counseling and behavioral therapy. I can tell you that I have had patients who have said to me, I want to go into a treatment facility. So we have a gatekeeper here in the county that I live in. We send the patient there. And when they get there, there are no beds in the facility. So they get on the wait list. The patient gets a call a couple days, and they said, we have a bed for you. So they go back in for the evaluation. The patient has not used since they were at the original evaluation. Now they're sent away because they no longer are in need. Well, you're not using. You must not have any need. There's something drastically wrong with that. We need to change the policy on that. We need to make sure there's access to care. We need to allow for medication-assisted treatment in jails and prisons and our criminal justice system. That's not all criminalization. We need to really work on medication-assisted treatment acceptance. We need to focus on public awareness as a chronic disease. We need to make changes as a person and as a provider. We need to adopt accurate, non-judgmental language, and we need to keep up to date because it's appropriate for those that are affected, for the disease of opioid use disorder, and for the therapies of treating opioid use disorders. States can promote comprehensive programs for opioid use disorder by, we need to expand care. We definitely know we need that. We need to expand access in the criminal justice system, and we really need to demand access to harm reduction and medication-assisted treatment. And some of the notes is that it's called motivational interviewing and motivational therapy, and that's true. I could have spent the entire 2 hours on doing motivational interviewing because that's really what we need to do and focusing on the patient and helping them at the spot that they are at. So thank you for that. We need to make sure we're committed on an individual level, changing our language, making sure that we are calling out people on the stigmatizing and shame that other people may be using. I've worked in mental health for 20-some years, let's say 26 years, oh my goodness. And in doing so, we talked about persons that had a mental illness. I walked into a meeting and I would start talking about mental illness, and they said, we say mental health. There is no mental illness, it's mental health. And so it was really good for someone to correct me, because for 20 years I was using the word mental illness because that's what we were using. And it doesn't mean it was right, but it was really nice for my colleague to correct me and make sure that I understood that we were putting it in a positive light. So on an individual level, making that commitment. At an organizational level, making sure that we have training, which all of you are doing today, and I'm so appreciative of it. The education, making sure that we are employing people of diverse backgrounds. We don't all have to look and act and have similar perceptions, but we do need to make sure that we are representing and have the ability to have diverse populations. We have to have assessment of the policies that we currently have. Just because it's been a policy for 5 years doesn't mean it's a good policy. It may have been a good policy, but some policies need to be changed. We do that frequently at our facilities where we're saying, is this the right reason? Or is this the right policy? And then we have outlets for feedback, making sure that people know that it is okay to question things. Should we be utilizing this term? Should we be utilizing this? In fact, we used to have a pain contract. It's not a pain contract, it's a controlled substance contract. And is that even the best wording for it? So we are constantly challenging ourselves to make sure that we are using the best terminology so that when we're talking with people, it's more patient-centered. And then at the community level, making sure we have awareness. Are there harm reduction services out there that we don't even know what they are? Are patients aware of harm reduction? We may want them to get full treatment for their opioid use disorder, but making sure, as in the public health model, that we're meeting patients where they are and reducing harm. So if somebody does have opioid use disorder and they're not ready for treatment, do we make sure they have clean needles? Do we make sure that they have clean paraphernalia? Even that word just sounds negative to me, but do they have the tools that are necessary to keep them healthy? Because we need to meet the patient where they are. And that does not mean that we have to say, we agree with your drug use. We just want you to be safer with your drug use. And when you're ready, we're here. All right. I want to go back to our thinker moments. So, and I want you to know the first thinker moment was my son, who is a college student, and that thinker moment was in a really tough spot in his life. And this is a picture of my daughter many years ago and her friend in front of the thinker at one of our local parks. But I want you to go back to the first questions I asked you. I want you to think about the times that you contributed to it or you didn't stop stigma. And I want you to take about 2 minutes to think how you personally or at your organization level or in your community level are going to decrease or prevent stigma. So in your practice, your community, and your personal relationships. And if you are willing, please share in the chat or in the Q&A. But I'm going to give you about 2 minutes. All right, we have someone that is stating that they're going to share this knowledge with their staff, and they're going to develop accountability amongst themselves. Great to hear that. Correct prejudice wording by staff and clients by giving educated words. That's great, too. Providing mental health first aid to community. I have actually paid for students to go to mental health first aid for them to help understand other people. It's great. There's some books that people have said are great to read as well. Unbroken Brain. I had a colleague recommend to me United States of Opioids, which is by a lawyer, so it gives a completely different perspective. We had a person state that at NA, some people are now saying, I'm so-and-so, and I'm recovering from disease of addiction, which is great. I'm recovering from disease of addiction. That's great. My organization is committed to training almost 500 people this year in mental health first aid, raising awareness about substance use and mental health disorders. That's wonderful. Somebody wishes a movement would enter Ocala. It is a very closed-minded community in general, so maybe there's something that can be done. Persons can come together. I don't know if there's any schools of medicine or public health or social work or pharmacy, but getting students to get involved and having a movement, having some education. I utilize students quite often for that. These are great. All right. I also want to make sure that the references are recorded. So here are the references. And now what questions do you have? Oh, I want to add a couple more. Some other comments are positive support groups with yoga, community service, education, gyms, and schools. That's true. We really need to make sure that we can provide resources and make sure that everybody is aware of things. What questions do you have for me that I can answer today or try to answer? I can tell you I'm not the person who has all the answers. I just have a lot of experiences and a large passion for this.
I have a question for you, Susan. Do you have information on shame that young adults ages 18 through 25 may face? I read a study that indicated that sometimes well-meaning adults, sometimes clinicians, recommend against opioid agonist treatment.
So you're looking for resources specifically for 18 to 25-year-olds?
Yes, that's what the question states, yes.
I use SAMHSA quite a bit for resources, but I don't think that they specifically specialize in 18 to 25-year-olds. One thing that I think what we need to do is really help clinicians to understand is that we don't have to have one size fits all with the medication-assisted treatment, and knowing that persons that are 18 to 25 may actually benefit from medication-assisted treatment and not have to stay on it for a lifetime. But having the conversation that it's okay if it is, I don't know that I'm definitely getting to the question here, though. If I have specific resources, I don't have specific resources for that group, but I think it's educating those clinicians on the different mindsets of medication-assisted treatment. Did that get the question?
Yeah, I think so. Another question that has come in is, do you think there will be a time when substance abuse disorder will be less stigmatizing and shameful? I think we've come a long way on addiction as a disease. Still time there is a lot of work to be done to make not just lay people, but the substance use field truly work towards this concept.
Yeah, I feel, without becoming political, I feel that we have come some distance. And it might be because I work in this field and I'm constantly talking to people about it. And I have an active audience of students that I'm constantly talking with about this, and I'm seeing some of those differences. We have a culture that is very media-driven, and unless we get on board with media and really counteract some of the negative things that are coming out, because every time we do something positive and make change, I feel like then I'm seeing somebody retaliate with a negative just as horrific, just like that original slide, or one of the original slides where it has the naloxone on there. I can see 3 or 4 of them in a day where I have maybe 4 or 5 friends who counteract that. There's just so much polar opposite thought processes on opioid use disorder. I think it's going to take time. I wish I could say, you know what, we could make such a drastic impact, but then we also have people who are digging their shoes in just as strong as us who are passionate about making sure we are decreasing shame and stigma. It's interesting because when I do these presentations, I usually say, how many of you know somebody with an opioid use disorder? Or how many of you, and you get through the room and everybody has had someone. But then if you turn the tables and you ask, how many of you have naloxone? How many of you want naloxone? How many of you believe in the harm reduction services? People aren't connecting all of that as being stigmatizing and shame-inducing, so we do have a long way to go. But we are coming. We're making baby steps.
Okay, I have one more question. When talking about people with substance use disorder, how often do people with substance use disorder mention feeling shame or stigma because of their disorder? Have you conducted an unofficial poll?
So I have not conducted an unofficial poll. I can tell you that even with people that I talk with about tobacco, people are shamed because of tobacco. People are shamed from vaping. And then I have patients who have said to me, I can't even leave my house because the family members don't want to be around me because of my opioid use. I have other people, basically what I get from the patients that I work with is that I need my opioids in order to function. And then we talk about that. So I haven't gone into the stigmatizing and shameful study poll, even though I have a couple of students right now who want to. I've done it with some of the providers. We have done some needs assessment and really looking to see about the barriers out there, but I have not done it with my own patients.
Okay, if any of the participants would like to, if you have any additional questions to ask Susan, this would be a great time to ask them, or we will move forward. But I'll just give you like 30 seconds to write the question, and if we don't receive any more questions, then we'll conclude the webinar.
So there is a question about medical marijuana. So this does get asked of me quite a bit about medical marijuana. I'm not certain what the full question is. Some people ask if they can use medical marijuana to help with their opioid use disorder. Usually one of the things that I talk about is why does somebody have an opioid use disorder? And we still need to go through that treatment. If somebody wants to use marijuana instead of their opioids, that is their choice. But we talk about still needing counseling if there's an addiction and misuse and abuse as to why that is occurring, and really get to those behavioral and the counseling as well. So people who then ask me, well, can I use it to get off the opioids? I'm a certified asthma educator, and I never support smoking. And I tell my patients that, like, I know smoking is great. You love it. It's bad for your lungs, and that's what I'm going to tell you. And I tell them, I understand why you smoke. You know, truth be told, I was a smoker. I love to smoke, but it's so bad for me. So I understand that people want to do things. So we have those conversations about why they actually do it. We do the motivational interviewing. We do the stages of change. I have a patient who says to me, Dr. Miller, I have COPD, and you are treating me great for it. However, I love smoking, and I love my pets. They both irritate my lungs really bad. I said, okay, as long as you're aware, and we have that conversation. Every time I see her, I will say, and how do you feel about smoking today? I am not going to stop yet, Dr. Miller. Okay, I just want to let you know that I'm here when you need to. And I do it with every disease state. Another question came in about what about oils? I'm still looking for some studies that show me that oils can be beneficial. Let me restate that. I'm looking for studies that are randomized controlled trials that have oils that they're studying oils that I can then make some evidence-based decisions on that. So the verdict is still out.
Okay, Susan, thank you so much for presenting today and sharing your time and your expertise and your knowledge. So thank you. Please note there's a couple items of business before we conclude today's webinar. When I conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email. The sender will be messenger@webex. Evaluation will close at midnight on Wednesday, May 1st. Statement of credit. We do not email statement of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. We have a great rest of your day, and please hold for the evaluation.